So we are going to go ahead and get started. Welcome everyone to the webinar, Complete Lung Cancer in Queens. My name is Elizabeth Aloni. I'm with Schneps Media. Schneps Media is the largest local media company in the New York metro area. We publish over 70 newspapers, magazines, websites, webinars, podcasts, and events throughout Queens, Brooklyn, the Bronx, Manhattan, Westchester, Long Island, the East End, and Philadelphia. Today, we are lucky to have the top thoracic surgeons from NewYork-Presbyterian Queens for an informative webinar to help raise awareness about lung cancer, its risks, symptoms, and treatment options available. Thank you so much for joining us, and let's meet them now. So first, I'd like to welcome Dr. Benjamin Lee. Dr. Lee is a board-certified thoracic surgeon practicing at NewYork-Presbyterian Queens Hospital located in Flushing. He received his medical degree from New York Medical College, completed his residency in general surgery, and his fellowship in thoracic surgery at New York Presbyterian Hospital. He's certified by the American Board of Surgery and the American Board of Thoracic Surgery. Dr. Lee specializes in the diagnosis and surgical treatment of disorders and diseases of the chest, including benign and malignant tumors of the lungs, esophagus, and the mediastinum. Welcome, Dr. Lee. Next, please welcome Dr. Oliver Chow. He is an attending thoracic surgeon at New York Presbyterian Queens and New York Presbyterian, and an assistant professor of clinical cardiothoracic surgery at Weill Cornell Medicine. He performs a broad range of minimally invasive thoracic surgery and complex airway procedures. His clinical interests include lung cancer, esophageal disease, and tracheobronchial malacia. After graduating from Icahn School of Medicine at Mount Sinai in New York, Dr. Chow completed a surgical residency at Beth Israel Deaconess Medical Center in Boston, where he also completed his cardiothoracic fellowship. He's received numerous awards for clinical care and teaching. As you can see, we are very lucky to have such experts with us. Welcome, doctors.
Thank you. We're happy to be here.
Wonderful. So let's get started. Let's just get started with the basics. What is lung cancer? Dr. Chow?
Yeah, so at its core, lung cancer is when a group of cells somewhere in the lung have started to become abnormal, and they start behaving abnormally. And this can take a lot of different forms, and there are a lot of different types of lung cancer, but at its core, it really is when they start to behave abnormally. They might divide more regularly than they should. They might start to invade the structures around them. They might even start to acquire the ability to move elsewhere in the body. And they do this by having and acquiring certain mutations. So once these cells start to become a little bit more, start to grow or enlarge or divide in an abnormal way, that's where lung cancer has started becoming an issue.
Thank you. That's a very easy way to understand it. Thank you for that. So speaking about that and the spreading of it, does it spread easily? Does lung cancer in particular easily spread?
So a lot of times when people hear about lung cancer, they are immediately terrified. And I think it's important to recognize that not every abnormality in the lung is lung cancer. There are a lot of different things that can be abnormal in the lung, and not all of them are lung cancer. When it comes to lung cancer specifically, though, one of the things that concerns both physicians and patients alike is that it has been known to spread easily. It's not necessarily that all lung cancers are really good at spreading. One of the challenges is that a lot of lung cancers are not necessarily easy to detect at an early stage, or at least they haven't been up till more recently. And so because a lung cancer may be present for many years, months, years, or even decades inside someone's body, sometimes it acquires the ability to spread without a person actually realizing that there's anything wrong inside of them at all.
Wow, so that would make sense why it could be caught later on and then be deemed as a more deadly disease when it's really not the disease, it's just as the progression of the disease.
That's exactly right.
Okay. So Dr. Lee, can you tell us, speaking about the symptoms that are hard to find, what are some of the typical symptoms of lung cancer?
Yeah, so definitely, just as Dr. Chow was mentioning, when lung cancer starts off, They usually start off as pretty small, isolated nodules, which generally won't cause any symptoms. You just imagine a small pebble in the ocean, it doesn't really create much in the way of a wave. The problem is when these cancers grow or they start to spread, that's when patients may develop symptoms. And they vary. They can be lung-related symptoms, so a patient could develop a cough or sometimes even cough up a little bit of blood. Patients could develop some shortness of breath or difficulty breathing. Sometimes it's pain related. But a lot of the symptoms that patients do develop that are directly attributed to lung cancer are usually found when these cancers are more developed or at later stages. Yeah.
So when should someone, if they notice any type of symptoms, what would be the symptoms that you would say, you know what, you should see a doctor about this?
I think that's a great question because a lot of the symptoms of lung cancer mimic problems that we encounter day to day. How do we know that someone's cough or somebody's little shoulder pain isn't related to bumping into the wall or getting something from their third grader who's been in contact with all of these other kids with runny noses? So, and I think that's one of the reasons why it is very difficult for a person to realize perhaps that they may have something more serious than a common cold. I think one of the tip-offs would be symptoms that don't go away after even a brief period of time. You imagine if you bump into something and you have a bruise on your back, now that should go away in a couple of days. It shouldn't continue to persist for weeks and weeks. And in the same way, a cough or symptoms of having some persistent phlegm coming up, that really shouldn't last for more than a couple of days if you imagine what a cold or even the flu might feel like. So I think persistent symptoms definitely should warrant. And I think the other aspect about lung cancer, which we probably will talk about more, is knowing that if you are at risk for lung cancer, definitely if you have a history of smoking or over a certain age, you might be in a higher risk category for lung cancer. So if you were to develop those symptoms and knowingly have risk factors for lung cancer, perhaps to be a little bit more proactive about seeking medical care.
Dr. Lee, that is a perfect segue because I would love for you to share, and Dr. Chow, for you to share with us, what are the risk factors for lung cancer? Who is someone that should be looking out for the potential?
Dr. Chow?
Yeah, so I think that one big risk factor that everyone is aware of is smoking. So people who have smoked a lot in their life are at an increased risk of lung cancer. But I think especially nowadays, and especially in our communities, it's essential to recognize that there's at least 10, maybe up to 20% of individuals who acquire a lung cancer who have never smoked at all. And I think that's really important to recognize because if we just think that lung cancer comes if you smoke, then we're going to miss a lot of individuals. In terms of other risk factors for lung cancer, growing older is a risk factor for lung cancer. Elder people who are elderly in age, beyond the age of 60, 70, that by itself, just getting older, is a big risk factor for lung cancer. Having a prior history of a lung cancer is another big and important risk factor. And then additionally, there are other risk factors that we might not always think about, but radiation exposure, exposure to secondhand smoke, a family history of other cancers, including lung cancers or cancers elsewhere in the body, all of those can also be risk factors for lung cancer.
Thank you for that, because I think, people are very focused on smoking, but that you should think about these other things as potentials. Also, what about, I feel like it's such a hot topic right now. I have a 10-year-old and a 12-year-old, and maybe that's why in particular, but vaping. Vaping has become really for all ages, have become a real concern. Is vaping also something that is dangerous and could lead to lung cancer?
Yeah, I think this is a very, very important topic, and it's something that we could spend another hour talking about, so I won't focus on it too much. While there isn't any confirmative lab research that shows that vaping leads directly to lung cancer, I think when you ask a lot of people who have spent a lot of time in these fields, who have studied lung physiology, lung cancer for a long time, a lot of us feel as though vaping by itself, just by the fact that it can create a similar inflammatory reaction inside of the lung. And just because we've known, especially early on with some of the vaping related illnesses, that sometimes it can cause severe inflammation inside young people's lungs, we somewhat expect that if someone exposes themselves to a lot of inhalational agents like the drugs that are in a lot of vaping sources, that it could increase the risk of lung cancer over time. And so I think that my general rule is if you can avoid inhaling different substances, then that's great. I think that a lot of people would not expect that vaping would be as risky as smoking, just because the number of chemicals and toxins in most cigarettes is higher and less controlled. But I think that no one would go out there and say that vaping is completely safe, and that we know that for sure.
Yeah, if I could add to that, I think the general idea, when we talk about the idea that age as a risk factor for cancer, there, from my understanding, there's no magical change that happens in a person's body when you turn 50 or 55 years old that says, oh, now we're ready for lung cancer. It's a cumulative thing where by living in Queens or living in America, we are exposed to more substances in the air that we breathe than, let's say, somebody living in the South Pole. And as a result, the toxins, whether they come from car fumes, cooking fumes, to a variety of other substances that we breathe, which we know carry carcinogenic, cancer-causing materials, over time creates this repetitive injury within our lungs, just like Dr. Chow was mentioning, which is akin to what vaping does. So if you're doing this when you're 20, 25, 18, 15 years old, you're setting up your lungs for this constant cycle of injury. And we know that cycle of injury and repair is a mechanism for which cancer can develop. So one of the concerns always is going to be any type of exposure that causes chronic harm and inflammation to the lungs is very similar to a lot of the other toxins that we encounter on a day-to-day basis living in a industrialized, quote unquote, first world nation.
That's a really good point. I remember when I lived in Manhattan and I would open my window, and if I would leave it for several hours, I'd come back and it would be filthy. And so you think about really all that stuff that you're ingesting into your body is affecting it. And both of you are talking about something that I think, really brings us to the question that I think can help clarify some of this is, what causes lung cancer? You say smoking, but what really happens in the body that causes lung cancer?
I think Dr. Chow touched upon this earlier, and it's one of those things where, on the biological level, we all have normal cells that every day are dividing. It's what we learned about in high school biology about the idea of mitosis, and where your cells replicate to replace themselves. But in the process of those cell divisions, every now and then there is a mismatch or an incorrect transcription of that DNA. Now, our body is actually meant to detect those mess ups, if you will, those mistranscriptions, and actually get rid of cells that are duplicated that are not normal. So at the basis, idea is that a cancer cell is just an abnormal cell, one that did not divide correctly from its predecessor, because the method of mitosis is ideally to create an identical offspring from the parent cell. So if you develop a cell that's not identical, it's by definition, it's abnormal, and it could then go on to become a cancer cell. But our body is meant to pick up those cells and destroy them before they become problems. Every now and then, though, they get away, and our host doesn't actually get rid of those cells. They're allowed to then grow on their own and then potentially develop cancer. So in that type of a setting, if there is a chronic injury, if there are areas that are causing the body to need to replicate more often, or create a situation where there's a constant repair and injury kind of a cycle, that's going to put your body at a higher risk for getting cancer.
And I think to add on that, I think that I like to remind individuals if they're faced with a diagnosis of lung cancer, or if they hear of a family member or a friend who has lung cancer, that there are many, many different types of lung cancer, right? We break apart lung cancers. We just call it lung cancer because it sits in the lung, right? But there are a lot of different types of lung cancer, and we split up by histology, what the cell looks like under a microscope. We split it up by mutations, whether or not the lung cancer has a particular mutation that makes it more likely to act in a certain way. We split it up by even within one class of lung cancer, we split it up by how it acts or how it's looking like it's behaving underneath the microscope. And so there are a lot of different nuances to lung cancer, and a lot that we've learned about lung cancer, especially over the past several decades, that has changed the treatment of lung cancer dramatically. And so it's not this singular entity of lung cancer and there's only one way to treat it. And if you get a surgery, you're great. If you don't get a surgery, you're not great. It really is, it's changed dramatically. And I think that because of that, there's a lot of hope if someone is faced with a new diagnosis of lung cancer. And I think a big part of what Dr. Lee and myself task ourselves with, just like others in the thoracic community, is by helping people understand what type of lung cancer is it that you're dealing with, or your friend or family member is dealing with, and how does it differ from other things, because it's not all the same.
That's really an important thing. I would never have known that there are different types of lung cancers, and then there are different ways of treating it. And the more you can learn about that particular type, the more, I guess, successful a treatment can be, potentially.
Certainly.
That's wonderful to know. So what is the best way to find if one has lung cancer? Now, let's say we're coughing, or we're at a certain age, how do we even go about finding it, since the symptoms are so difficult to determine?
I think that, traditionally there are a lot of different tests that we run. There are a lot of different, techniques that people have done on physical exam, but obviously seeking medical care is going to be the first step. And, whether it's seeing your primary care doctor or having your primary care doctor refer you to someone that specializes in identifying patients with lung cancer. But a lot of times, most doctors may start with getting a routine chest x-ray, which has been the common test that's been ordered for decades. I think one of the important things that we've actually learned over the last 10 or 15 years is that x-rays may not be the best test to detect lung cancer, just because as a two-dimensional picture, it can miss a lot of things that are maybe hiding behind other structures in the chest. So in general, CT scanning has really been shown to be a much better way of detecting lung cancer. It's more of a three-dimensional picture, so we can actually get a much better view of the lungs. In fact, our most recent studies for screening for lung cancer, which is something I think we probably will be talking about, involves the use of low-dose CT scans as a method to detect lung cancer in patients that are at risk for cancer. And we've had a number of major studies that were recently published that showed how CT imaging is far more beneficial in detection of lung cancer than regular chest x-rays.
Okay, so how does it start? How does the screening start? Is it based on a person's age? Is it based on some of those factors that you mentioned, whether it be smoking or family? How would one start that check and move to screening?
So I think the big important starting point is patients that have symptoms versus patients that don't have symptoms. So if you're a patient that does have symptoms that might be of lung cancer, you're not really going to be in the screening category. You're going to be in someone that needs to be worked up to see, why are you coughing? Why are you having pain? And is it because of something that's real? The other category would be someone, let's say, that doesn't have any symptoms, that wants to know, could I have a cancer that has yet to show any symptoms that could be detected earlier? So those are the folks that we would direct towards more of a screening pathway. And a lot of this is based on the studies that were performed. There were some major national trials looking at lung cancer screening. And those studies focused on a select group of patients that they felt at a higher risk. So these are patients that have smoked for a long period of time, in which the criteria that was set was what we call a pack year, a 30-pack year smoker, which is the equivalent of a person smoking 1 pack a day of cigarettes for a year, so for 30 years, or someone, for example, that smoked 2 packs of cigarettes a day for 15 years is also considered a 30-pack year smoker. And then the age criteria used in the studies was generally an age of 55 years and up. The more recent lung cancer screening criteria have actually dropped the age to 50. So right now, the criteria that we look at, just for simplicity, are people over the age of 50. So that's where that age and that lifetime exposure of just, community or environmental things comes in. And then folks that have also had a 30-pack year history of smoking. So anybody with meeting those 2 criteria today in America qualifies for screening for lung cancer. And that's if you contact your doctors and ask about that. Here at Queens, we have a program set up for lung cancer screening, and a lot of other health systems across the United States do as well. And you can get a low dose CT. So this is a very toned down CT. So there's not a lot of radiation being given. In fact, the amount of radiation in one of these scans is just barely more than a mammogram that women would get for screening for breast cancer. So it actually, it's not the amount of radiation exposure that people kind of have tied into traditional CT imaging. Dr. Chow, do you have anything to add?
Yeah, I think that lung cancer screening is, to a lot of thoracic oncologists and surgeons like us, is very important, because one of the things that we touched on before is that in the past, decades ago, lung cancer was almost always found at late stages when symptoms had developed and when the cancer had already been growing and starting to invade other things, and was a much more difficult disease to treat. One of the real pluses and one of the real benefits of finding an effective way to catch lung cancer early, which is the chest CTs that Dr. Lee has been talking about, is that we have the opportunity in certain individuals to find lung cancer at an early stage when it's potentially curable by surgery alone or by other means. And I think that is one of the reasons why a lot of us are very eager to get the word out there. And so if you have someone that you know in your family who has smoked very heavily, don't worry about all the specifics. If they're above the age of 50, you should ask them, hey, maybe you would be eligible for a lung cancer screen. Have you ever talked to your doctor about it? New York-Presbyterian even has a number that we could release later to just call, and over the phone, they will screen to see whether or not you are eligible. The specific criteria, like Dr. Lee was talking about, is between the ages of 50 and 80, 20-pack years of smoking, currently smoking, or have quit within the past 15 years. But it's not necessary to remember all that. All you have to recognize is, hey, I'm a smoker. I might be at an increased risk of lung cancer. And if I fit in that age range, 50 to 80, I would be eligible for lung cancer screening. I think that one of the other things is a lot of us nowadays are dealing with what to do with chest CTs, which a lot of people get for all sorts of reasons, going to the ER, having some cough or something that doesn't go away for a little while, or bumping into something and arriving in an ER. We get a chest CT and it has some abnormality, and then we have to figure out what to do about it. And I think that the first thing to recognize is that it's not necessarily lung cancer if there's something in the report that says there's a nodule somewhere or there's an abnormality. And to recognize that it takes steps to find out whether this is something to be concerned about and how concerned to be about it. And there are a lot of individuals, not just thoracic surgeons like ourselves, but there are a lot of doctors who are ready to help you make those sort of the steps necessary in order to figure out whether it's something to be concerned about or not.
That's a really good point that you bring up, Dr. Chow. Talk a little bit more about that. How do you confirm that there's a diagnosis of lung cancer as opposed to something that is other than that?
Right. So there are a lot of different ways that we can diagnose lung cancer specifically, but to diagnose something in a true fashion, it requires the ability to biopsy it. And so either we get a needle to pass through that lesion with the help of our interventional radiologists, or we can sometimes, we can do a small procedure where a patient is placed under a general anesthetic. We put a little video camera through the airways and take samples of the lesions in the lung that way. Or sometimes we can do a small surgery under general anesthesia where we take out a lesion that is concerning and very likely to be a cancer. A lung surgeon or an oncologist by looking at the pictures, by seeing whether or not something has been changing over time, by seeing whether something is acting in a way that is more active than usual, will determine whether or not an abnormality in the lung is likely to be a cancer. And then based off of that, to make a recommendation as to what the best approach is to confirm and potentially to treat a cancer if it is a cancer.
Great, thank you for that. So you would have a scan, they would see something that was abnormal, and they would decide based on that what type of biopsy or what type of camera, which is really incredible what's able to be done to be able to determine whether it's cancer or not. Is that correct?
Right, and I think that to break it down, oftentimes if someone comes to an office either with a concerning symptom or a chest CT that shows some sort of abnormality, it's our job to be able to help delineate whether you, the patient, or your family member is someone who's at high risk of developing a lung cancer, and whether that abnormality has shown any change over time, because lung cancers, they generally grow over time. Sometimes it's slow, sometimes it's fast, but they're generally growing. And so sometimes if there's an abnormality seen in a chest CT, we might just choose to watch it. And that may be the right thing. We don't want to do surgery or biopsies on things all over the place if it's not necessary, right? And if it's an abnormality that we think is high risk to represent a lung cancer, then we will likely recommend what the best way of making a diagnosis to confirm or refute the fact that it's a lung cancer, and then go from there. But once we make a diagnosis for lung cancer, then there are other steps in place that help to define what the best treatment plan is, especially because not all lung cancers are treated the same.
Well, that's a perfect segue, Dr. Chow. Can you share what happens after, or let's turn to Dr. Lee. You can share a little bit what happens after a diagnosis of lung cancer is confirmed. Who do we need to see? What happens at that point?
Sure. Like lung cancer is very similar to a lot of other cancers that are treated, in which the absolute diagnosis of lung cancer is only one part of the information that's truly important. We usually really stress that the idea of the stage of the cancer can be actually even more important sometimes than even the diagnosis itself. We've alluded multiple times during this talk about somebody having something maybe early or something late, someone having spread of disease. And those are all terms that we use that are linked to the concept of stage. Generally speaking, if you were to ask what's the definition, how you define stage of cancer, most people may have heard of terms like early stage, late stage, stage 1, 2, 3, 4. And those are all terms that we as doctors use to help determine in many ways how early or how perhaps advanced a cancer is. The general idea is that something early or stage 1 would be a lung cancer that's isolated just in one area of the body. And obviously someone that has stage 4 disease would have cancer that's spread to other parts of the body. And those middle stages typically involve cancers that have spread to lymph nodes. So usually the next step to answer your question after you have a diagnosis, or sometimes even before having a diagnosis, is to do some examinations that focus on staging. CT imaging, for example, even though it may show you the lung nodule, for us, it shows a lot more. We look at lymph nodes, we look at presence of fluid around the lung or other nodules that may be present. But beyond CT imaging, we usually will get a PET scan once we have a diagnosis of lung cancer. The PET scan is another form of a CT, but it's more of an activity test. And it will scan our patients from basically their ears to their knees. So it's a whole body scan. And the patients get an injection of some glucose, a sugar that's been labeled. Sugar is basically the fuel for the body. You get hungry, you eat a Snickers bar. I don't work for Snickers, but that makes you feel happy or get some more energy. But the idea is that at rest, when we're just sitting around, if you were to do that test, the only parts of our body that should be active are the heart and the brain. So when you do these PET scans, if you're completely normal, ideally nothing lights up other than your heart and your brain. But we also know that certain things like tumors, and lung cancers being one of them, have a propensity to take up this sugar because they're active. The cells are dividing, they're growing. So we'll see that a nodule or a tumor in the lung may light up. But the true importance of that test would be to see if anything else in the body lights up that shouldn't be. And that helps us guide some of the staging. So if we see somebody that has a tumor that also has things lighting up in the bones or other organs of the body, we then may be leaning more towards somebody having a more advanced cancer versus somebody that has nothing else lighting up except for that single nodule in their lung. So staging becomes a very important part of what we do as a next step. This can be done by surgeons that take care of lung cancer. This can be done by medical oncologists, sometimes even by radiation oncologists. We all participate in care of patients with lung cancer. So most of the physicians in those specific fields, and pulmonologists as well, I don't want to forget them. We all understand the ins and outs of lung cancer care and the workup with not only the diagnosis, but the staging aspects for lung cancer.
And I know at New York Presbyterian, all these different doctors work very closely together for each patient to make sure all these different areas are covered. And can you speak to that a little bit about how you all work? Because you just named a lot of different doctors.
Right, and that's
how a patient is cared for. Once they find out they have lung cancer, once they find out where their stage is, what are the typical treatments and what kind of doctors are involved in their lung cancer care?
Right. We definitely have a team first approach because we realize that in many patients with lung cancer, they may need more than one doctor involved in their care. In one way, doctors, for example, that we get together is we actually have these meetings we call tumor boards, where we actually get together. We used to get together physically before COVID. Now a lot of it's done virtually, but still, nonetheless, we actually have these ways of discussing patients on a level where doctors of all specialties can chime in and give their thoughts on care. The other aspect is that we actually frequently communicate either by cell phone or texting or in person with a lot of our colleagues, just because we're all located in a very similar location within the hospital. So we can frequently discuss patients that may need additional doctors in their care. So it's a very multidisciplinary approach to lung cancer, which we really feel is the best way of treatment of lung cancer.
You can certainly feel at ease knowing that you have the best specialists in different areas to be able to analyze what's best. So share with me a little bit about what are the different types of treatments for lung cancer.
Dr. Chow?
Yeah, so when it comes to the treatment of lung cancer, the first steps that we already discussed are diagnosing and confirming that it is indeed a lung cancer that we're dealing with, and then staging the lung cancer, meaning figuring out how far the lung cancer has moved in the body or whether it's remained very localized. In terms of the treatment options of lung cancer, I generally like to split them into two main categories. There are some treatments that work locally, meaning it's a surgery that removes the cancer and removes it from the body entirely, or there is also radiation therapy that can treat the cancer in a very confined location using externally imposed radiation therapy. Then there are other treatments that are aimed to treat the cancer systemically. And it used to be just several agents of chemotherapy, but in recent years, there are now many different treatments that can sometimes be targeted to a particular cancer. oftentimes we think of these treatments when the cancer has started moving to lymph nodes or elsewhere in the body. And so we know that just treating the cancer where it looks abnormal in the lung is no longer sufficient. And these types of treatments can range from chemotherapies to immunotherapies, or basically medicines that harness and teach the body's immune system to fight the cancer, to find and fight the cancer. And then there are also targeted therapies, which are therapies that are geared towards treating very specific genetic pathways, basically. Some cancers have a particular mutation that makes them act in a particular way because of that mutation. And there are some treatments, if you recognize that that mutation is what's causing the cancer, there are some therapies, either IV treatments or oral pills, that target that particular pathway and either reverse or stop that pathway from occurring, which treats the cancer. And so I think that all this to say, there are a lot of different treatments for lung cancer. The treatments are nuanced, and that's one of the reasons why when someone receives a diagnosis of lung cancer, it may very well feel like they're shuttled around to all sorts of different doctors in all sorts of different places. But the reason for that, and I like to try to reassure my patients, is that the reason for that is that we know a lot about the best ways to treat certain lung cancers, and we want to make sure that we're giving the right treatment for the right disease.
That makes a lot of sense. So what about the risks of treatment? Whether you mentioned many different things from chemotherapy, radiation, medication, what are some of the risks of these treatments?
I think overall, it's in medicine, we obviously always know that with any treatment that is offered, there is going to be some aspect of risk and benefit. One of the foundational wisdoms is that lung cancer that is untreated universally is fatal. There is a time difference. Some people do have, we've kind of mentioned, some people have very aggressive cancer, lung cancers that may be deadly within weeks to months. We also know that there are certain types of lung cancers that are very indolent, that may go on for months to years without causing significant harm. In the same way, the treatments that are offered vary. Obviously, some are surgical, for example. So with any kind of surgery, there is a risk that you inherently deal with, whether it be bleeding or some infections or risks of anesthesia. With chemotherapy, there's the general ideas of what chemotherapy can cause, from fatigue, hair loss, infections. So every treatment that we offer obviously has a potential risk. Usually these risks are actually pretty infrequent. For example, I can speak to surgical risks probably better than most other specialties, that is. But for us, most lung resections can be done with a risk profile that's well less than 1% for any major problems. And in this day and age, most of the operations we do are all minimally invasive now as well, which really allows for enhanced patient recovery, return to work, and things like that. So I think overall, just in the last 20 years, there have been a lot of advancements across all fields, whether it be in better technologies for radiation delivery. We don't have our radiation oncology physicians on with us, but they will definitely agree if I were to tell you that the machines they're using today are far more accurate than the ones they had 30 years ago, so that they can actually be much more precise in their delivery of radiation, avoiding radiating structures that might otherwise get affected. And they can deliver a much more powerful dosage to a specific area better than they ever could before. So that technology has improved. And just in the same way, Dr. Chow was mentioning, the drugs that we have for systemic treatment have also improved. No longer is it just chemotherapy. And a lot of the newer drug treatments, whether it be immunotherapy or targeted therapy, have a much different side effect profile that in many ways is actually easier to tolerate for patients than traditional chemotherapy. So a lot of it is the balance between risk and benefit, but generally speaking, not treating lung cancer usually is not a good ending. So we definitely feel that if a patient's able to tolerate treatment, it's usually the better choice.
It sounds very hopeful, hearing that the the risks of treatment are very manageable, and that also there are so many specific ways to treat it based on the type of cancer that it is, and also how critically important it is to treat it so that it doesn't continue to grow. But I can say it definitely is very hopeful to hear these things, because I think a lot of people hear the word the words lung cancer and think, the most awful of awful. But the reality is, if you can make sure you get screened and you find it as quickly as possible and see doctors as professional and experts as you and your team are at New York-Presbyterian, that it can be a much better outcome. So how does lung cancer affect someone's daily schedule? I know that might sound like a very unimportant question, but it's something that one worries about when they're faced with lung cancer. Does it change the way you can behave and live your life? What would a patient expect? Dr. Chow?
Yeah, I think that when it comes to the treatment options for lung cancer, the reality is there are a lot of different treatment regimens. And it could be as small as a short stay in a hospital with a minimally invasive procedure to remove the lung cancer, and then someone is effectively cured, might leave the hospital after just one night in the hospital, and then just be set up for being watched to make sure that the lung cancer doesn't return. Or sometimes if the cancer is more advanced or has been growing for longer, it might require different forms of therapy to be used in combination. It might even involve using chemotherapy and radiation first, then followed by surgery, and then sometimes even followed by more treatments after. And I think that in that sort of second scenario, that would be treatment that is spanning potentially several months of time, potentially even longer. I think the reality is that because there are so many different types of lung cancer, and also because each stage of lung cancer is treated differently, there definitely are important decisions to be made both between the doctors and the patients and their family members, but it's a conversation, and it's not necessarily something that is done and then set in stone, meaning that if someone starts upon a treatment, but then finds it very hard to tolerate, it doesn't mean that they have no other option but to continue, right? Part of our job as physicians is to be able to recognize this is going to be working for you. This is what is the best evidence. This is what the science tells us about the best way to treat your cancer. But then the other aspect of it is we need to find out what will work best for you as an individual, because you're the one going through the treatment. And I think that that's a very important part of it. So it could be something that seems very short and not disruptive at all in someone's life. And other times it can be very disruptive. And it's part of our job to be able to help you navigate that sort of journey.
Thank you.
I think one of the main aspects also is that the overall goals of treatment are what Dr. Chow is alluding to, in which, I think traditionally it's always been how long can you keep somebody alive? And I think we've realized nowadays that as important as that is, the quality of the person's life sometimes is even more important than the quantity, in which, when we talk about some goals of care for people, we really want to be able to return people back to their normal lives. So there might be a temporary disruption to have chemotherapy or surgery, but with successful treatment, we also realize that cancers of all stages have, especially earlier stages, really have the potential to be cured. And in that setting, although their lives may have a temporary disruption, the goal is to get them back to their normal life, after that temporary disruption.
Thank you for that. So I want to ask one final question before we get to our attendees' questions, because we have some great questions. But I think people, with COVID still around, people have some concerns. What would you say about safety and getting screened for lung cancer during COVID? Dr. Chow?
I would say I'll let Dr. Chow answer this one.
No.
I know what I would say. I think Dr. Chow.
No, please.
Yeah, I would say that especially in view of how COVID is relatively much better controlled now in New York and in our communities, I would say that if you have any concern for either having lung cancer or you have concerning symptoms, you should not let a fear of contracting COVID keep you from going to a doctor and seeking care. I think lung cancer is one of those things where we want to find out whether it's truly lung cancer quickly and efficiently, and we want to treat it efficiently because the ramifications for not doing so are pretty severe. And especially now, I think the hospitals are very safe. Even in our current hospital, we stay masked. Everyone stays masked within the hospital. There are still certain restrictions. If someone is coming into the hospital for a procedure, they're tested for COVID in advance to make sure that all our admitted patients are free from COVID infections. And so I think that for the most part, we feel as though the safety of our hospital system is very high, and all our employees are vaccinated. And so I would not allow, especially at this point, I would not suggest refraining from treatment or seeking out any sort of treatment because of a concern about COVID infections.
Yeah, and if I could just add one quick thing, I totally 100% agree with what Dr. Chow said. And I think one lesson that we actually learned from COVID was that in general, the entire population of the world put their healthcare on hold for about a year and a half. And there actually are papers and research studies that are being written that are showing the sequelae of doing that is that patients in the cancer field, and not only just the cancer field, in heart disease, in other lung diseases, diabetes, across the board, patients are now showing up with very advanced stages of disease just because they have not basically had any medical care from fear of leaving their house for the last year and a half. So we're seeing of late, a lot of newly diagnosed cancers that are very late stages. And perhaps a year and a half would have made a difference, but we were in a different world or society that during last year. Now with vaccinations, with rates that are very under control, with medications to treat COVID that are now recently approved, contracting COVID doesn't equate a horrible outcome as it initially did last year. So I definitely would encourage people to seek screening, whether it be for breast cancer or prostate, colon, and lung, because I think these are all very important preventative measures in cancer care.
Well said, and so very important. In fact, I'm going to share right now, you can make an appointment at NewYork-Presbyterian Queens if you call 718-670-2707. I also put it in the chat. You'll also get an email tomorrow with that information. Don't put it off. As these incredible doctors told you, the sooner you catch it, the better they can manage it for you. So if you take anything, if you have a loved one who's afraid, have them watch this and make sure that they're screened and safe. So thank you so much for that. So if doctors, it was okay with you, I'd love to get to some of our attendee questions. So we have a question from Sue, who is in her 90s and wants to know how dangerous is a biopsy. She said she has honeycombing and she wants to know if there's a difference in danger between going through the back or through the throat. Doctors?
Dr. Chow?
Yeah, sure. I would say, Sue, a lot depends on an assessment of your overall health and your other medical conditions. I think that abnormalities in the lung can be approached in different ways. It's hard for me to know without actually seeing where the abnormality is, whether or not it's safer to be approached by bronchoscopy, which is the video camera down the throat, or whether it'd be safer using a needle, which is done from outside the body with a needle that passes into that area of abnormality and takes samples and biopsies that way. The big difference between those two approaches in obtaining a diagnosis is one is done with at least some level of more significant sedation and potentially general anesthesia, which is the bronchoscopic modality, whereas the other is done with light sedation and usually just some local anesthetic by the skin. I think that is one of those things where you will need to likely trust or seek out a particular cancer doctor in order to define what is the better approach for you and whether you are safe to undergo such a procedure.
Thank you for that. And I do want to reiterate that, Dr. Chow and Dr. Lee are incredible experts, but of course, everyone's situation is different, and you should certainly call and make an appointment to be able to get real direct answers, very, very specific answers to your disease or screening. Joyce has a question. How dangerous is ground glass opacity? Am I saying that correct?
Opacity.
Opacity, thank you. And is surgery always necessary?
So I guess I'll take this one. The answer is that a ground glass opacity is something that can be frequently seen in a lot of patients and doesn't always equate lung cancer. We generally can have a really, really long discussion about this, but to give kind of the Cliff Notes version, in certain types of lung cancer, there is a development process where it can go from something precancerous to something very indolent to something very aggressive. We see that in, let's say, colon cancers, where a person may have a simple polyp that gets removed and the doctor will tell them it's no big deal, it's just a little polyp. But then the reason they take them out is that a small percentage of polyps can actually turn abnormal and then turn into colon cancer. Lung lesions are the same way, where someone that has a certain type of lung cancer, typically something called adenocarcinoma, before it becomes a very invasive cancer, it usually starts off as something very pre-invasive or something just maybe barely atypical. We have a term called AAH, which stands for atypical adenomatous hyperplasia, which is not cancer, but it's just kind of an overgrowth of tissue. And those are lesions that typically look like ground glass nodules. So frequently someone that has a ground glass nodule may have something that's pre-invasive or actually precancerous. For us, when we see such lesions, the size of the nodule matters, as well as the number. Some folks have multiple of these. Some people have one. Some people may have one that's 5 centimeters in size or 5 millimeters in size. So all those factors actually become very important. Sometimes we will recommend just simple observation, especially if they're small, just to see, do they grow? Do they change over time? Especially since most of these end up being not cancer. Larger ones that may have a mixed appearance, so part of it's ground glass, part of it's solid, those we may encourage getting a biopsy or perhaps even having them removed. So there's a lot of decision making that does go into ground glass nodules. It's probably one of the more frequent things that Dr. Chow and I will see. And the rule of thumb is true. No two ground glass nodules are the same.
So make your appointment and find out which category you have. Thank you for that. Caroline said, would you use the same treatment on a patient with advanced cancer, or are there different ones since a lot of these medications are new?
Yeah, so I think that for this question, Caroline, the reality is there are a lot of different criteria by which we decide what the best treatment is. For lung cancers that have reached the very advanced stage, meaning that they have spread to different areas inside of the body and outside of the lung, that they have metastasized or are stage 4. There are different criteria by which we select the medications. And usually there is a first line approach that involves some form of immunotherapy. But there are also other criteria by which we select whether or not a chemotherapy is necessary or whether a targeted therapy may be appropriate. And a lot of that is based off of the specific molecular characteristics of that particular lung cancer, and also the particular type of cancer it actually is, because again, not all lung cancers are the same. And I think that this is one of those areas, especially the treatment of more advanced cancers, is where we rely very heavily on a multidisciplinary approach, meaning the joint efforts of surgeons, medical oncologists, and radiation oncologists, because in certain situations, the treatment is going to rely not just on one specialist's sort of forte. It may actually very much rely on the coordination of efforts from all our divisions.
Terrific. Thank you so much. You've been so generous with your time. I'm going to ask one quick question because I feel like it's an important thing to reiterate. Judith said she was diagnosed with lung cancer over 2 years ago. She had radiology at NewYork-Presbyterian. She also had 1 month of chemotherapy and has scans every 3 months. Nodules have not grown from when it was diagnosed. That's wonderful. And she feels well and doesn't have coughs or shortness of breath. Is there such thing as not having any effect, yet it's still a cancerous nodule? So no symptoms, could you still have cancer?
I think, hi, Judith. So, obviously your situation is going to be unique from anybody else. And it's one of those things where it sounds like you received a treatment, and if your scans have been stable, we can never really know for sure, but generally speaking, if we have a patient with stable imaging, we consider that a success. Especially that, the idea is that cancers, when they're bad, when they're doing things, they're going to grow, they're going to change. So when we have a patient that we may treat, whether it be with chemotherapy or radiation or surgery, we're looking for stability of scans over time as the surrogate marker of successful cancer treatment. Going in and just simply doing surgery on everyone is just not practical to prove if somebody is completely cancer-free. So we do rely heavily on our imaging studies. And when we do find somebody with very stable imaging after their treatment, many times we consider that a success. So congratulations.
Hey, Judith, that's wonderful, and wonderful to hear from a patient from NewYork-Presbyterian Queens. Thank you for that. I want to thank you so much, Dr. Chow, Dr. Lee. You're so busy. Thank you for being so generous with your time and your information and really making this understandable to all of us. I want to thank our attendees for joining us. Please, as I said, we have this recorded. Please watch it again, share it with your family, share it with your friends. We want to get this information out there so they can heal more and more people and they can support more and more people. It's really important. Make sure you reach out, make your appointment. As I shared, the phone number, the email, the web address, it will be all emailed to you tomorrow, as will where you can find the link to this edited recording. And I wish you all just a wonderful evening. I wish you all to stay safe and stay healthy. Again, doctors, thank you so much. Have a wonderful evening, everybody.
Thank you. Good night.
Thank you.
Good night.